Department of Pharmacology. Drugs having primary effects on psyche, mind, and osses. Diseased or abnormal condition, overall the mental process and used for treatment of psychiatric disorders. History of psychopharmacology. Treatment to dope. 1952 Chlorpromazine, Risperidone research. TCA and MAOI, 1957. Benzodiazepines, 1960. 1980 onwards, novel drugs. The disease often imprecise, overlap and depends on predominant symptoms to decide drug therapy types. Types of disorders, DSM-4 and ICD-10. 1. Psychoses, disorder of thought, behavior and 2. Comprehend reality. 2. Affective disorders, disorder of mood. 3. Neuroses, less serious, no loss of comprehending of reality. DEFN, these are serious psychiatric illness with serious distortion of thought, behavior, capacity to recognize reality and of perception, delusion and hallucinations, misperception and misevaluation. Loss of contact with reality, loss of ability to comprehend reality. Classification. 1. Acute and chronic brain syndromes, cognitive delirium, and dementia. Toxic or pathological basis is present brain tumor, drugs, etc. Confusion, disorientation, and defective memory, and disorganized behaviors. 2. Functional disorders, no underlying cause. A. Schizophrenia, split mind, splitting of perceptions and interpretations from reality, inability to think coherently, and auditory hallucinations. B. Paranoid states, paranoid individuals constantly suspect, persecutory, the motives of those around them, and believe that certain individuals, or people in general, are out to get them. Delusion, these are fixed, false beliefs that are outside patient's culture firmly held. Hallucinations, abnormal sensations. It is a sensory perception without a source in the external world. May be visual, auditory, olfactory, and tactile, etc. Illusion, it is a mistaken or false interpretation of a real sensory experience. False belief, delusion of persecution. The real shadow of the hallucinating person transforms into the corporal image. Disorders of mood. Mania, elation or irritable mood, reduced sleep. Hyperactivity, uncontrollable thought and speech. Associated with violent behavior. Depression, sadness, loss of interest and pleasure, worthlessness, guilt, physical and mental slowing, self-destructive ideation. Bipolar. Unipolar. Less severe and ability to comprehend reality is not lost, mild disorder, anxiety, depression. 1. Anxiety, unpleasant emotional state, concern for future. 2. Phobic states, fear of specific persons/objects/situations. 3. Obsessive-compulsive, limited abnormality of thoughts and behavior, but recurrent intrusive thoughts or ritual-like behavior. 4. Reactive depression, physical illness/loss. 5. Post-traumatic stress disorder, war, riots, earthquakes and tsunami. 6. Hysterical. Neurotransmitters of mental illness, dopaminergic and NA and 5-HT. 1. Phenothiazines, S, C6H4, 2NH. Aliphatic side chains, chlorpromazine, CPZ. Trifluoperazine. Piperidine side chain, thioridazine and mesoridazine. Piperazine side chain, trifluoperazine, fluphenazine. And perfenazine. 2. Butyrophines. Haloperidol, Trifluoperidol. 3. Thioxanthines, Fluphenazine. 4. Other heterocyclics, Pymazide, Loxapine. Clozapine. 5. Atypical antipsychotics, Risperidone. Olanzapine, Quetiapine, Aripiprazole and Ziprasidone. Chondrium. Tricyclic structure, 2 benzene rings are linked by a sulfur and a nitrogen atom. Nature of substitute at position 10 influences pharmacological activity. Divided into 3 groups on the basis of substitution at position 10. Effect of CPZ and Risperidone on laboratory Animals and psychiatric patients. Differ in normal and psychotic individuals. In normal, neuroleptic syndrome. Effects are appreciated as neutral or unpleasant. Different from typical barbiturate action. Indifference to surroundings, paucity of thoughts. Psychomotor slowing, emotional quietening, and tendency to go off to sleep, easily aroused. Minimized spontaneous movements, but no ataxia or slurring of speech. In psychotics. Typical psychotic patients, less agitated, more communicative and responsive. Aggressive and impulsive behavior diminishes over a period of days. Hallucinations/delusions and others come to normal. Neuroleptics, emotional quietening with neurological effects, tremor, rigidity, bradykinesia, etc. Ataxia and dysarthria do not develop in normal doses. Tranquilizers, major and minor. All phenothiazines, butyrophines and thiazanthines have same antipsychotic efficacy, but potency differs in equieffective doses. Low potency, aliphatic and piperidines, and high potency, others. 1. Antipsychotic effects, low potency, more sedation. Prompt sedative action, tolerance develops. Antipsychotic effects take weeks to develop, but no tolerance. Valuable in early treatment, added value in agitated psychotic patients. But not used as anxiolytic or sedative. Performance and intelligence are unaffected relatively, but impaired. Vigilance, high-potency drugs. 2. Extrapyramidal effects, more with high-potency drugs, less in thioridazone and atypical ones. 3. Lowers seizure threshold, low-potency drugs, piperazines lower propensity. 4. Loss of temperature control, high doses, poikilothermic. Medullary and other vital centers. 5. Antiemetic action, all except thioridazine. Drugs sedative, extrapyramidal, hypotensive. Aliphatic. Side chain. Plus. Piperidine plus. Piperazine plus. Haloperidol plus. Low potency, fewer EPS H1. Alpha 1. And muscarinic. High potency, higher EPS, but lower H1. Alpha 1. And muscarinic. Behavioral effects. Conditioned avoidance response inhibited. Remember, what is it? Dopamine hypothesis, dopamine theory of schizophrenia. Overactivity of DA in limbic area. Drugs which increase dopaminergic activity, amphetamines, levodopa and bromocriptine, etc., induce or exacerbate schizophrenia. Density of dopamine receptors in post-mortem of untreated. Increased. PET in treated and untreated, untreated increased. Homovanillic acid, HMV, changed in treated patients in CSF and urine. Most antipsychotics block postsynaptic D2 receptors in CNS. Except clozapine, like atypical ones. Site of action being limbic system and mesocortical areas. But initial rise in firing of DA neurons and DA activity increases initially, followed by tolerance to increased activity of DA in basal ganglia. Parkinson-like effect. But no such effect in limbic area, continued blockade. Hypothesis not complete, several atypical ones do not interact with D2, other receptors, serotonin. ANS, alpha-blocking activity. CPZ equals TFLPRMZN thioridazine clozapine. Fluphenazine haloperidol. More potent compounds, lesser alpha-blocking. Property weak anticholinergic property. Additionally, phenothiazines weak H1 and anti-5-HT property. Alpha-blocking, anticholinergic, weak H1 and anti-5-HT. Local anesthetic action. Skeletal muscle, no prominent action, spinal. Reflexes are not affected. Reduce certain types of spasticity, basal ganglia. Action. Drugs receptors blocked. CPZ alpha 1, D2 and H1. Haloperidol. Fluphenazine and thiazanthines. D2 only. Promethazine D2 and H1. Clozapine, Risperidone, serotonin.